most recently we started we started doing interview webinars with our customers, and obviously I know you've taken the CHSO training with us in the past and always attended our conferences, so it just made sense to reach out and schedule this with you.
Yeah, and Dr. Delgado and I are going to be next month. We're going to start kind of a pilot program for EPICompliance for imaging and
Oh, that's awesome.
CHSO for imaging. So we're going to be launching that. Hopefully, you want to do it this month. I'm just swamped this month, so have to be next.
Yeah, no worries. No, I'm interested in I when I talk to Dr. Delgado, he's got such a busy schedule. It's the conversations are usually pretty quick, but he didn't mention that to me. I'm interested in learning more about that pilot program.
Yeah, I've got to build it first.
Gotcha. Gotcha.
I'm going to be building it next month.
Okay. No, that's awesome.
Yeah.
Might be that kind of gives me maybe an idea. We might have to do another one of these in the near future to talk about it, Why not?
Yeah, sure.
But we'll go ahead. It's 1:34. We'll go ahead and get it going. So, as I mentioned, George, we do a little trivia question from the previous week's webinar before we actually start the presentation. So that's what we're going to go ahead and do now. I'm going to share screen, and everybody welcome in on today's webinar. If you guys were on last week's event, we did talk about secure data disposal. We interviewed one of our compliance partners, Mr. Brad Ward with Shredaway. So if you were on last week's webinar, this question is going to pertain to that subject matter. So if you weren't on the webinar, again, appreciate you guys' attendance today. And you guys can always take an educated guess as well. No harm, no foul. So I'm going to go ahead and share screen with everyone. George, if you want to let me know if you can see chat, if you guys can see it, just throw a one or an emoji. I'm assuming all's good. You said, George, you can see it?
I sure can.
Awesome. So today's trivia question is, what should companies look for when selecting a qualified compliant shredding vendor? And the choices are A, the lowest cost service available, B, a vendor with a NAID AAA certification and documented chain of custody, C, a vendor that offers free shredding services. That's kind of interesting. And D, a vendor that provides on-site repair services. So go ahead and put your answers in chat, please. George, if you want to take a guess as well, feel free to place it in chat or feel free to voice it.
Well, if I picked anything but the correct answer, I think I would lose my CHSO certification. I think
It's better that you don't say anything then.
I have to say B.
I like to throw in some funny answers every once in a while. This was a good one. Listen, low cost or free? I mean, hey. Jose, put your answer in chat. Come on. We'll give it about 20 more seconds. What's wrong with free? It's not always a bad thing, Jose. All right, so we'll go ahead and give out the answer. So again, the question was, what should companies look for when selecting a qualified compliant shredding vendor? Again, the choices were A, the lowest cost service available, B, a vendor with NAID AAA certification and documented chain of custody, C, a vendor that offers free shredding services, and D, a vendor that provides on-site repair services. And the answer is, in fact, B, a vendor with an NAID. I'm just going to say AAA certification and documented chain of custody. For those of you that weren't on last week's webinar, just to clarify, that NAID certification, it's provided by the National Association for Information Destruction. It signifies that the vendor adheres to stringent standards for secure data destruction. ensuring that sensitive information is handled and destroyed in a manner that complies with legal and regulatory requirements. So again, if you're looking for a data shredding company, definitely one of the things to look for. And then obviously when it comes down to the documented chain of custody, for those that don't know, this refers to detailed tracking of the data from the point that it is collected to the point that it is destroyed. Having this documentation, not only from a HIPAA standpoint, is crucial, uh, but for compliance. But it again, I guess that it's it's a crucial point, that a crucial document to have in accordance to HIPAA compliance. Sorry, I butchered that, but again, the answer is B. I appreciate you guys participating in today's trivia, and we'll go ahead and dive into today's webinar series. George, I'm going to pull up just a quick PowerPoint. We'll get going.
Okay.
So again, welcome everyone, and thank you for joining us today's webinar series, EPICompliance Customer Insights. Today's topic, we are going to be talking about revolutionizing decision-making in healthcare imaging. I'm Ray Walters, and I will be your host. I'm excited to welcome our guest expert today, Mr. George Kastroulis, who is a CEO and CHSO of Express Medical Group and exclusive partner of EPICompliance. Express Medical Group is a leading provider in medical imaging and currently serves the local community of Placa, Florida. George has over 30 years of experience in this industry and is here to answer your questions. We have several questions lined up for you, George. But before we get started, just give us a brief overview of your background, a little history, how you started Express Medical Group, and obviously the services that you provide.
Sure. I've been in many different health fields over the 30 years, mostly imaging. That's been where I started my career. That's where I'm at. But I am CEO of Express. We're multidisciplinary practice, urgent cares, family practice, wound cares, imaging. I've been leading companies from home health care to urgent cares, you name it, PT companies. So healthcare is kind of where I've lived in the past 30 years, specifically in imaging.
Oh, awesome to hear. And I know you had some distinct awards. How do you pronounce this? Is it the Mallinckrodt Award? Can you tell us a little bit, tell the audience a little bit about that award in radiology and the
So
importance behind it?
yeah, there's a few that I had mentioned on the CV, the
Hmm.
Mallinckrodt Award and the Margaret Crumley Award. Mallinckrodt was a distinguished award way back, actually, in my beginning of my career, because of in college showing some aptitude in imaging. The Margaret Crumley Award is probably what I'm most proud of the two. That is an award that's given yearly to alumni of the college I went to
Hmm.
that have most advanced the field of science. Through my work with breast cancer mortality rate reduction and helping to further breast cancer, the field of breast cancer in Volusia Flagler counties, I received the Margaret Crumley Award. And that's a big reason why I'm with Express. We noticed that mortality rates in this interior of the state of Florida were much higher. I met with the state of Florida health department, and they shared statistics with us on how Putnam County was leading mortality rates in Florida. So part of my agreement with the owners of Express was we would focus on bringing those mortality rates down by improving the quality of care and access to women health in the area. So that's really a passion of mine. That's a focus of mine. And I continue that work even down to today.
No, that's awesome to hear. I appreciate you enlightening us on that, and that's awesome, awesome award. And well, um, let's go. So we'll go. You know what we'll go ahead and do is we'll dive into the questions. I know Jose, you had a couple. We certainly talked about a couple as well. Um, so oops, I went too far. Apologies. There we go. Um, So, a question for you, George. How do you see advancements in medical imaging technology revolutionizing decision making in healthcare? And I couldn't help but notice when I tried to do a little bit of research before this. I was on your website. I saw that it sounds like you guys have a lot of state of the art equipment at your imaging center. So, I was wondering if you can just sort of enlighten us on that and the decision making involved with this.
Sure, and I'll give you a warning. By having me on, I'm someone who could talk. So I'll try to get through all five questions. You may have to stop me partway
Yeah,
through.
sure.
Um, so when you see the advancements in medical imaging has grown so much in the past few decades that in the past, as new medical modalities and techniques have come out in imaging, they've just been added to the treatment protocol of patients. Well, that's
Mm,
been changing because healthcare costs are spiraling out of control. And so many studies now are showing that we are outpacing other countries. We're coming out with so much that we're outpacing spending. 2018, the Journal of the American Medical Association, JAMA, came out with a study saying we're twice as much spending. So it's caused our industry to really look at the decision-making process of healthcare. We know we're coming out with great techniques, great ability to diagnose. Instead of adding it to the treatment protocol, can we rethink decision making of healthcare? Can we rethink the protocols? Can we rethink what comes first in the decision making process? Where does imaging come into it? And where does the diagnostician and their clinical side come into it? Instead of throwing, now we have thousands of tests until instead
mm.
of a shotgun approach of adding more tests, what makes sense, both to patient care as well as the financial side.
No, great answer. And Jose actually had a sort of a side question to that. He said, with the advancement in technology today, do you find that the gap between mobile and stationary machines has closed, or has that gap maintained?
So that is a fantastic question. And it's really a difficult one to answer, and here's why. We'll have to be honest. We're in a free market system,
Hmm.
which is great. It's what's led innovation in our community and our country. So we with free market, it means that we're constantly innovating and we're constantly competing. Now that's a positive thing. So it means that there's much greater technology coming out every day in the mobile market. But it also means that there's opportunistic individuals who want to make a dollar. So I'll give you an example. You can get a 1980 or 19, let's be honest, 1990s, 2000 vintage imaging equipment.
Hmm.
Just like a television at home, your 1990 television is not going to, you're really not going to watch the Super Bowl on it. It's not the
No.
same as what you're going to buy today. Yet you could put one of those in a mobile imaging van, bring it around to a center, and Medicare will pay you the same amount as my $2 million MRI, and they'll get theirs essentially 10, $20,000. So if you're looking at a straight business perspective, mobile is great, and you're going to pay very little for it. Yet the patient will pay the same amount of money, and so will the insurance carriers. So because of that, and
Interesting.
because of people being in it for not quite the right reason, you still see a lot of mobile equipment that just isn't very good. Now, that being said, there's great mobile imaging equipment. The same thing now that you could see in an imaging center, by and large, you could put in a mobile unit. It just really depends on the ethics and scruples of the people running the imaging. By and large, what you see in mobile imaging isn't as good just because of that. Does not mean they don't exist. A lot of hospital systems are putting great pieces of equipment from PET
Mm.
scanners to MRs to ultrasound. We have a mobile ultrasound fleet that does just as good as any stationary ultrasound. It really depends on who's manning it.
You just answered my follow-up question. I was curious to see if you had any mobile units available. That's awesome.
Yeah.
He said, so Jose said, so would you say that mobile units should be used for more simple diagnoses, confirmations like ACL tears?
They can be used for extremely complex diagnosis, like a mobile PET CT, for instance. You can get one of the top of the line time of flight PET CT units. They're a little harder to calibrate, but it's possible in a mobile. and you're going to have very, very pinpointed diagnosis. ACL is not that simple of a diagnosis, and here's why. You have, I'll give you an example, a stationary open MRI. That's a 0.023 Tesla magnet. It's a very weak magnet. Not many people even manufacture them anymore, but they're out there as open
Mhm.
MRIs. People gravitate to them. It's very difficult to see ACL tears because we're imaging hydrogen atoms, and the ligaments are very hydrogen poor, so you don't see them well. However, a 3 Tesla magnet is a state-of-the-art unit. There's great software which shows you cartilage, shows you ACL. That is going to be a great study for an ACL, and you can put a 3T in a mobile. So it really, it's a tough one to say that mobile's less diagnostic. Again, it goes back to who's operating it.
Mhm. Jose, to answer your question, assuming yes.
I had to put him to sleep. Sorry.
Yes, but it brings more up. Well, we'll dive into the next one. George, no, that was great information. Is there any specific answer or examples, I'm sorry, where innovative imaging technology has led to big advancements in patient care? And based off what I'm hearing so far, it really sounds like with these imaging units, it seems like the technology with that's always it's getting better.
It is, and I have a few examples. Here's one. So, if you look at the field of prostate cancer, so over 3 million men 40 years of age and older in the United States have a PSA over 4. Now, when you're looking at the treatment algorithm of a PSA over 4, there's a significant cost. The traditional algorithm was send a patient for biopsy. Now, once you send them to a biopsy, the American Urological Association says that that will cost over $2,000. And if you find cancer, it's going to cost $15,000 over the next 3 years. So we come out with MRI prostate. It is the gold standard
Wow.
for evaluating prostate cancer and seeing. We give a PIRAD score. And what PIRAD is, it gives you the essentially the clinical significance if there is cancer. Most prostate cancers are so slow growing, even if they're there, do they need to be monitored or do you have to go take the prostate? There's a difference between that. So instead of just throwing MRI prostate into the mix and just continuing as business as usual, this has kind of flipped the industry on its head in thinking of the algorithm. So now what we're looking at is physicians and on the family practice level use a
Mhm.
multivariable risk prediction tool to see the significance of what they're seeing clinically. Then the first step is to send for an MRI of the prostate instead of going through the prostate biopsy, which can lead to adverse occurrences, adverse results, so
Sure.
those kinds of things, or a missed cancer where you'll have to do another biopsy. So you do this first, and depending upon the risk associated, if it's a low risk cancer, well, then they're followed up clinically. If it's more of an intermediate risk to high risk, then they're sent to the urologist for the biopsy. It's completely changing. They're looking at this now and finding that if you can be more conservative in the treatment, you actually will not just save lives. You see no change in the mortality rates, but you see that the cost, the 3 year cost drops from $15,000 down to $1,900 per patient. So by
Wow.
looking at how imaging falls into that algorithm, we're actually changing patient care. We have another one of cardiac imaging, CTA coronary. Before, any patient with any kind of cardiac event or strong family history sent to a cardiologist, they're run through the gambit of imaging. We can do a stress test, Holter monitor. We do an echocardiogram. The list goes on. A cardiac cath could be a $10,000 cardiac workup. CTA has come out with
Mhm.
100% sensitivity and 84% specificity. That means it's much more accurate than anything else out. But instead of just throwing CT into the mix, there's an institute called the National Institute of Health and Care Excellencies, or NICE. It is the agency for the United Kingdom that sets guidelines of how physicians should treat and proceed. What they found is changing the algorithm. If the patient has something such as evaluated for stable angina, they're sent first for a CTA coronary, very low cost study. It will tell you definitively if you have plaque in the arteries. If there's no plaque in the arteries, there's no need for a $10,000 workup, and you're clear at that point. Or if there's a mild stenosis, or if it's in a location that's not one of those widow makers, the family practice doctor takes care of the patient pharmacologically. If it is something to be concerned about, you go straight to cardiac intervention, where you bypass all these other procedures and go get your stent in, or go get your bypass. By thinking of where the technology fits in and changing the algorithm, it helps advance patient care. NICE has found out that
It's huge.
such studies have found to drop breast cancer mortality rate by 50%. So it's it's much better to rethink and work with partner doctors than just adding technology to the same old.
No, that's awesome. And I'm just curious, in terms of this sort of technology, how is this available anywhere in the U.S. Or I'm just thinking out loud. Like if I'm in a rural area, and I want to get I want to get my prostate checked or however, is that like would I have to travel somewhere for that sort of treatment or to get those results, or is that something
So
that's pretty common now?
that's a great question. And the answer is, for the most part, yes. You have to
Mhm.
have equipment like a 64 slice CT or a 3 Tesla MRI. 3T MRI, a good one, is going to cost you about $2 million to install. A good 64 slice CT is going to be around a million. Costs money. And then you have to have the
Sure.
doctors who actually know how to interpret this. So usually larger institutions, inpatient and outpatient, is where you see it. What's kind of nice about Express, when I took over CEO, I had brought it to our owner. I said, if you want me to be CEO here, we have to change the community. And he said, that's exactly what I want to do. So we looked at a rural community of Putnam, is where he lived. And when he wanted a 3T and a 64 slice CT, I told him, doctor, you realize you'll never make a dime. And he said, that's okay. My family lives here. My patients live here. We're going to do this for the right reasons. So you're starting
Love
to
that.
see that popping up in rural communities, a few here and there, of individuals who are in medicine for the right reasons. They'll put these in. Other than that, you do have to gravitate to larger cities, larger practices, teaching institutions. They have the know-how on how to run them and the equipment, but don't discount rural communities. You're starting to see a change, because some of us are just, we realize we're not going to make a ton of money either way. So why not bring the best to the patients?
No, good point. And to your point as well, obviously I'm a Jacksonville native, very familiar with Palatka. Hey, that's a growing area. I've seen some growth there. So y- your owner might be on to something in the long term.
That's true.
Jose had a question for you. How is AI affecting the imaging specialty?
That's a
Good
good
question,
question
Jose.
too. So AI has a multitude of facets that interact with our industry, from AI scheduling to the back end. Imaging actually is starting. Our MRI, for instance, is one of the more sophisticated MRI. I don't trust it, so I turned it off, but it has an AI protocol where, for trauma, if a patient comes in for a trauma brain, you just have to put them into the MR scanner. It will do everything from set up the protocol to set up the slices to scan them in 5 minutes, and you get them out. You get to send a report to the doctor. I don't necessarily
Well,
trust it. I have a technologist there, so there I still want to control the patient side, but the AI helps with the diagnosis. Here's an example in breast imaging. Breast imaging, we have qualified radiologists, great breast radiologists. They're reading mammograms, thousands of mammograms in a year, but yet we use what's called computed aided detection. So the computer, first of all, looks at the mammogram and it flags anything that it feels is cancer. Then the radiologist reads the mammogram. Then after he's done, before he releases the report, he pulls up the AI, their results. He compares it, and then And if he needs to adjust his report, he adjusts his report. This is happening in a lot of area. Computer detection is, and artificial intelligence is in MRI, CAT scan, and many, many various areas.
Do you find a significant difference in diagnosis confirmation from your radiologist and the AI?
No, but American College of Radiology and RSNA has done a big report that it depends on the radiologist. So
Mm,
fellowship trained breast radiologists and radiologists who do thousands and thousands of MRI, I'm sorry, of mammograms a year are typically much, much more accurate. So they're usually on par with what you see in AI. What happens is when you have the radiologist who kind of does everything, is the jack of all trades. He reads a little bit of breast here, he reads a little bit of MR here. It's almost like boy, what's a good it's thinking about playing football and you have one football player that plays every single position. He's not going to be the best quarterback of all time. He's not going to be the best linebacker of all time. Not because he's not talented or he's not brilliant. It's just because when your attention is diverted to too many different specialties, it's difficult to become the master of all. Those cases, the AI can help even more than what they help the breast. Even though the fellowship trained breast rad still uses the AI, it's going to tend to you. Studies have shown those doctors who don't focus on breast do miss more, and it will help there.
no, that's great. Um, Appreciate that insight. And how does your experience in healthcare compliance? I know you took the CHSO training. What was it? Was it last year or was it the year before? I know, or no, it was last year when you took the Certified HIPAA Security Officer training. Correct?
It was now 2 years.
Has
I've
it been
been
2 years
doing
already?
this for
Good
a
Lord.
while. Yeah, yeah.
I don't know where the
So,
time goes. But so how
yeah.
does your experience in healthcare compliance intersect with the adoption of, new imaging technologies and such?
It's not just technology, but it's also legal changes to our institution and to our specialty. So as legislation changes, you have to keep up with things. CHSO, I think every imaging organization should have one. But also, even as a CHSO, I still have coupled with a company to actually it is EPICompliance, but I've coupled with a company to assist because so many changes and it's hard to keep up with them. So I'll give you an example. MQSA, so we are legislated in imaging by the American College of Radiology, by CMS and Medicare,
Hmm.
but mammogram special, that is also legislated by the Food and Drug Administration. So we fall under MQSA guidelines. Guidelines are completely different. So you have HIPAA compliance that you have to fall under for the rest of imaging, but mammograms, MQSA releases you from HIPAA in a few ways. Why? It's because the mammogram is a woman's right in the state of Florida and in this country. They can walk into any imaging facility. It's their right and get a mammogram. They don't need a prescription. It's the only study that does not need a prescription. Now, there are HIPAA standards a lot of imaging companies aren't aware of, and that comes into marketing. So we discussed, let's go back to some of the examples that we mentioned. CTA coronary,
Hmm.
it can save lives. It's a great study. We could very easily send marketing material as an imaging center to every man and woman over the age of 50 who has a family history of high blood pressure, high cholesterol, saying this is a great study. That would violate HIPAA standards. A lot of imaging centers don't realize their marketing may violate HIPAA. Not so with mammograms.
Hmm.
MQSA wants you to reach out to the women who are your patients and tell them, regardless of whether they signed a marketing acknowledgement or not, they want you to send out reminders and flyers and innovations on breast cancer. They want you to keep people educated and informed. So that's where
Interesting.
understanding the laws helps, especially with the imaging field. And then there's things like self-referral acts and anti-kickback acts. And that's where working with an organization and having someone with CHSO knowledge helps. You're not allowed, you may want to dispense some of this information with, say, the local cardiologist about what you can do and can't do.
Hmm.
There are anti-kickback laws which prohibit you from using funds. towards education up to only a certain amount of money per doctor per year and only in an educational. Well, how much is that money? You can't necessarily rent out a restaurant and invite all the area cardiologists to talk about CCTA, but if you don't, the doctor doesn't want to come and waste their time. So how do you dispense that education? That falls into compliance. That falls into where it intersects when new technology comes out. You have to be very, very versed in the laws, and I would not advise going it alone.
No, good point. Um, always have an attorney on hand for sure.
Yeah.
um, Jose, Jose, he or George may have answered this question, but he asked Jose asked if FDA is involved here. Is there an alphabet agency that is not involved with healthcare now?
No, there's not. And actually, it scared me a little bit when we started to see Florida legislation. They wanted to add other layers on top of layers. We were going to have to do OSHA, and then we had to do a Florida OSHA. But thankfully,
Ugh,
that kind of I think got buried. But no, there's so many different agencies, and each of these cost money. Eventually, it's going to cost more to practice than actually any profit in it.
no, good points. And Jose, if you got anything else, feel free to chime in. I'm gonna, uh, based off what we've discussed so far, what challenges do healthcare organizations face, especially those that are trying to integrate imaging solutions into their practice, and how can those challenges be addressed?
So it really depends where you're looking. If you're looking as a medical doctor, as a family practice, and you want to integrate imaging into it, that opens up a whole new host of legal issues and get a good consultant before you get into that. If you're talking about an imaging center that wants to integrate advanced imaging solutions into a practice, if it's that's the side, it's really you have to make it work. It's so
Hmm.
difficult these days of falling reimbursement. Um, Hospitals have it a little bit easier. They run off of a different fee schedule. That's why if you go to a hospital and you get a bill for your MRI, it's going to be $3,000, $4,000. You go to an imaging center, you get a bill for your MRI, it's going to be a couple $100. It's not because the imaging is inferior, it's just the hospitals can legally charge more. Each one of these technologies we talk about brings a huge cost to the center. And not only cost, you have to find the skilled radiologists. And those are not inexpensive either. So it's a dollars game sometimes, or it's throwing that out the window and deciding you want to do it for the right reason. Now, not that money is a bad reason. You have to have money to pay your employees and move forward. So it's a tough, tight wire act as far as a practice trying to integrate not necessarily the equipment, but integrating these services into your patient care algorithm. Where to get started is research. Um, Going to some of these compliance meetings. Last year I gave a talk on how specifically family practices could integrate in an algorithm prostates. I talked about cardiac. I talked about knee MRIs and back MRIs, and at what point and where in the treatment algorithm do you have peer-reviewed articles that show you where you can integrate? That's the most important thing, is not relying on what you learned in medical school or in practice over the years, but finding resources, reading, staying up to date in imaging. The RSNA is a great location. The American College of Radiology, the Journal of American Medical Association, all of these areas will have fantastic algorithms published as technology advances and changes of where you can go. Don't necessarily listen to the marketer from the local imaging center. Talk to a radiologist and read, and that's what's going to really help with trying to find how to adapt to the advances.
No, good point. And Jose mentioned radiology replacement data AI.
Yeah, yes and no. So I read one of his questions on the chat that radiologists, are they afraid? Yes, radiologists are always afraid of losing money. That's why they push the legislation so hard to make guys like me go out of business because it does take away from radiologist-owned imaging centers. And there are PAs out there and nurse practitioners that have helped other fields, but radiologists have really pushed down um, some of the extenders, radiology assistants. They could help, but they're very limited because they don't want to lose the industry. So yes, they are afraid, and rightfully so, but there will always be a need for the human eye, because it's not just numbers, and it's okay to say it's all numbers, and but to trust AI completely to be the last word. What if something is missed? Do you want it to be your mother who dies of breast cancer because it did miss it? Because I have seen, conversely, radiologists find cancers that AI has missed. So I think the future is a tandem collaboration between software that uses AI and a radiologist who has the expertise, who kind of could look at clinical symptoms across the board and not just go headlong into one diagnosis, but look at the patient in the totality to see what's going on. I think a good collaborative approach is really the future.
So when you're looking for a radiologist for your practice, you're looking for somebody that's not just, obviously not just, they're truly, looking to find I guess, the best solution for the patient or
Yeah,
diagnosis.
yeah, and I've really compartmentalized my
Yeah.
imaging center. So why I've done that, the RSNA has mentioned a report that there's something called auto referral. Journal of American College of Radiology came up with the term auto referral. When a radiologist sees something, he might say, "Oh, this is a potential brain tumor, but it may be cancer. It might have come from the liver. It might have
Mhm.
come from the spleen. It might have come from the." So I recommend imaging everything. So that's what's called auto referral. The radiologists kind of build their own referral base, and they don't mean to do it sometimes. They're just afraid of being sued at times. And the doctor being afraid about being sued, they'll order what's on the report. So what I've done is I've compartmentalized my imaging center, knowing that not everyone could be a specialist in every field, and knowing that there is something called auto referral going on, and it may not be, like I said, malicious. It might just be they're
Mhm.
protecting themselves.
Sure.
So I've siloed the radiologist. My breast radiologist is a breast radiologist. If he recommends other imaging studies, he will not see a penny from that because he's not going to read it. Even if he orders the biopsy, I'm sending it to somebody else to do the biopsy. The vascular doctor who reads my echocardiography is not going to be the same doctor who reads for a CTA coronary. So if he recommends it, it's for the good of that patient. And he's a specialist just in echocardiography. It's going to go to CTA, who's going to be read by a doctor who that's all he does for me is reads for that. My MRI might go to a neuroradiologist if it has to be neuro-based, or a musculoskeletal radiologist. And if they continue to order more, it's not going to go to them unless there's a need for continuum of care. If it's something that is in the same vein that they're chasing and it's going to help the patient by having the same radiologist, great. But siloing and finding the expert in the given specialty is really a key. And you'll see that in a lot of bigger radiology groups as well. They have on site all of these specialties. So depending on what's needed for the read, it will get allocated to the right radiologist.
So Jose mentioned nothing like malpractice paranoia to dictate clinical thinking.
Yeah,
uh,
that's absolutely true.
he said, if you so you self isolate to depress unnecessary imaging. Jose, you're cracking them today. What is one specialty that doesn't order much imaging that should?
I would say family practice. Here's why. Family practice should be the gatekeeper. And in larger cities where there are many specialties, sometimes doctors get complacent, and it could be a very simple diagnosis. They were trained to figure it out and be the diagnosticians, but sometimes they just send out the referral. I don't want to mess with this. I don't have time. I need to get cranked through. And some of it is the HMO fault. Some of it is they put such stress on the doctors to see so many patients, they can't spend the time. So doctors, family practice doctors do not make what they used to. they're trust trying to keep the lights on. So they're sending it out to the providers. That's bringing healthcare costs up, but not only healthcare costs, now the patient has to spend huge out of pockets to see specialists. And some of these are absolutely warranted.
Mm,
But if a family, I'll tell you what happens in a rural setting where there's no specialty doctors around, the family practice doctor has to rethink the algorithm. So instead of sending a patient for a specialist, before they do, there's a very simple medical tests that can tell them whether or not the specialty is even warranted. It'll save the patient the cost, it'll save healthcare the cost, and it'll help with the patient's anxiety levels and not having to send them to a specialist, do this, that, to be able to get to the actual diagnosis much more concisely by getting
sure.
to. So family practice really needs to lead the charge in imaging. The other thing I see is family practice is all over the place with questions. The industry is kind of tossed. You have people like the preventative task force saying that the U.S. Preventative Task Force that breast mortality or breast imaging shouldn't be done but every other year. Then they said it shouldn't be done until after you hit 50. Then they found out they were losing a lot of women and people were dying because of their recommendations. So they just inched it back down to 40. Other organizations like American Cancer Society, American Medical Association, a whole plethora of them came out and said these people are stupid. You got to do them every year if you want to save lives. So sometimes the doctors are just confused, so they're not even ordering mammograms. So it's
Huh.
really goes back to the family practice doctors and the internal medicine doctors. They need to be the ones who understand imaging and understand not ordering excess, but ordering appropriately.
Makes sense. I would say they're sort of considered the front line, if you would, with their patients. Let's see if we got any other questions.
And I'm
Jose,
sorry,
I
I
hope
told
that
you I could
answered.
talk a lot. I've taken much more of my time, so I appreciate than what you originally allocated me.
Yeah, we'll George, if you don't mind, we'll go through our last question and we'll open up just for a quick FAQ, and then like I said, we'll have to certainly get you on another one in the near future, and
Sure.
maybe talk about this Epi project.
Sure.
But last question for you, from your perspective, how can a revolutionization of decision making in healthcare imaging lead to broader improvements in overall healthcare delivery and patient outcomes?
So there is actually push going back to the questions that Jose was posing about AI. Are there is a push for decision-making software, helping the provider, as we mentioned, the family practice, the gatekeeper, trying to decide what to do with this patient. Where screening and finding things early has been proven to save lives. So one estimate from the U.S. task force says $3.7 billion can be saved if we diagnose people earlier through preventative screening. Now, take above and beyond preventative screening, just ordering the correct test up front, knowing what advanced studies are out there and ordering them up front is going to help with not just cost, but also outcomes. When you can diagnose a patient more accurately, quicker, it's always going to improve outcome. Finding cancers in the earlier stages, finding other disease processes earlier from there's give you an example. There's I see anecdotally on the rise with our patient level, our patient census, we're seeing temporal arteritis. Now that's a hard one to diagnose, a very easy one to diagnose in imaging, but the imaging test isn't often ordered. We go through 100 other tests before we hit that one. If you diagnose that early and get the patient a high dose of prednisone, you could save lives. If you diagnose them late, well, we just saw a patient not in our practice, but a patient that was lost because it was diagnosed a little too late.
Mm,
You have, if you could diagnose a patient, the prognosis changes. So early diagnosis is pivotal to anything we're doing. That means revolutionizing decision making. It means understanding the advanced imaging techniques, but understanding where they fit in the treatment algorithm. They're not just a sidecar add-on to more spending. It's changing the algorithm, knowing how to use it to help the doctor be a diagnostician, finding out what the cause is and helping and treating the patient. That's really where we're going to see. And when that happens, we're going to start seeing those outcomes improve. And we already have in our field, they are improving, but it just needs to be more widespread.
No, absolutely. Good points, George. And again, I appreciate your time. And I know we went a little bit over, but really, this is some very great insights into this. And I've certainly learned a lot from this talk as well. Um, what we'll do is we'll open just for a quick questions and answers. We'll just make it a few minutes. If you guys have any questions, please feel free to chime in here in the chat, and we'll go ahead and George will do his best to get those questions answered.
Well, Ray, I think I might have bored people out of the room.
You know what? I think you crushed Jose. I don't think he's got anything else that he can he can throw at you. Well, I'll tell you what, George. Again, I appreciate your time, and for those that joined us today, very much appreciate your participation. If you guys would like to or if you guys have any questions, concerns, and you guys would like to get in touch with George, I did put a slide here with his contact information. George, hopefully I got that right.
You did.
um,
Yeah, you did.
and like I said, George, I hope to see you on another one here soon. Maybe we can dive into, I don't know, maybe something a little more specific in imaging. We'll have to we'll have to discuss, but we'll definitely love to have you on another one sometime soon. And again, I appreciate your time for joining us today. And
Yeah.
again, for those that were in here, we will be editing and sending this recording out to everybody as well. This will go up on our YouTube page. If you haven't already, please like and subscribe to our social medias. Again, this will allow for the latest updates. Like I said, we do these webinars weekly on a Tuesday basis, and if you follow our social media channels, you'll see what's sort of going on and see what the topics are that we'll be discussing. Next week's topic, we will be discussing payroll compliance for new and established businesses. We're going to be interviewing Mark Resco for that. He is a local payroll company here based out of St. Augustine, Florida, and we're excited about that. So just be on the lookout for some correspondence and link to that registration. And again, George, appreciate you once more, and hope to see everybody on that webinar next week.
Thank you for having me, Ray.
No problem. Thanks, George. You have a great rest of your day. Everybody have a great rest of your day, and we'll see you next week.